Yeah, I guess we'll go ahead and get started. I'm Elena Rios, President and CEO of the National Hispanic Medical Association, and we're here with our COVID-19 briefings. We really are shifting now to talking more about our Vaccinate for All campaign that is for not only COVID-19, but all vaccinations. And we're very impressed with all of the audience and the speakers over this last few years. This is our 22nd webinar. We started monthly webinars, and then this year we moved into quarterly cadence for the webinars. But we've always found a topic that's important, and especially to learn about how to deal with our essential worker families, especially Latino families and other underserved families, and getting the tips from our colleagues who are experts in the area that we discuss. So today we're really going to discuss the importance of vaccines for pregnant women, especially minority women. And we have with us a great lineup of speakers. I'm going to introduce them in a minute. But I just want to be sure and let you know that we do have CME credits for the doctors, nurses, and pharmacists on the call. Here's our learner notification. It's a little busy, but basically it's 1.25 credit hours. And if you don't know how to get the information, we will have QR codes at the end, and also our great staff. Susie and Megan will be sending information out after the call. Next slide. We have some housekeeping, just to let you know that all your microphones should be muted, and to please let us know your questions in the Q&A box for the panelists. That we will have discussion after all three lectures are done. We're here until 15 minutes past the hour, 8:15 on Eastern time. And we also have a post-webinar survey that will also be emailed and on a QR code at the end of the slides. Raffle prizes are available upon completion. And, it's hard to let you know how important it is, but in order to get your CE credit, we do have to have evaluation. And we want to know if there's anything missing or more information that you would like us to find for the next time we have a discussion about vaccinations in pregnant women. We also have a recording and the slides that will all be up on our website, nhmamd.org, in about a week. Next slide. So just some insights. We know how important maternal mortality has become in this country. If you look at all the countries in the world, the disparity continues to grow in the United States, especially for minority women. And between 2019 and 2021, the maternal mortality rate among Hispanic women more than doubled, rising from 12.6 per 100,000 live births to 27.5 maternal deaths per 100,000 live deaths. The rate of maternal deaths among Black women in 2021 was 2.5 times higher than that of white women, while the maternal mortality rate among Hispanic women more than doubled, again, from 2019 to 2021. A little bit of a duplication there, sorry about that. Hispanic women have faced higher rates of COVID-19 infection, likely due to increased exposure as essential workers, and we also know because of intergenerational living, overcrowded housing, and just women, especially women who are pregnant. Everybody wants to help the pregnant woman and their families make sure she doesn't overdo anything. So she's always being surrounded by family, which increases the exposure rates. And barriers to vaccination and testing, including language barriers, fear of deportation, misinformation, have all disproportionately affected our Latinas. And so we're going to hear more about the solutions and the strategies. But I think next slide, our first speaker is actually from CDC, and just to put a plug in for NHMA's major grant from CDC that started in February of 2021, we started our education campaign that we started, that we call Vaccinate for All. We have some updates, not only our briefing series and champions. We have a brand new monthly newsletter to those who are Vaccinate for All champions so that we can showcase what our champions are doing. We have champions that are individuals around the country, not only health professionals, but community-based leaders, public health leaders, but also we have organizations, and we'd like to showcase and share accomplishments as we move toward vaccination strategies that among our community so that we can share ideas and strategies, not just talk about the problems. And we also have a new challenge for champions, a monthly feature in our newsletter, which comes out on the second Friday of every month, to share their incredible accomplishments again and showcase what they're doing. And we invite anyone to be a champion at our website, nhmamd.org. And then, of course, the last accomplishment there is the Bridge Access Program from the U.S. Department of Health and Human Services to be able to have adults get more vaccines covered through Medicaid and Medicare. As the Medicaid unwinding happens in our communities, we know that people don't know that they can still get free vaccines. And it's important for adults because in this country, we've not really had a mandatory vaccine push like we did for children. You know, you can't really go to school without having vaccines unless you have some exemption. But we really need to push our adults to have vaccines too. Next slide. So our first speaker, Dr. James Lee, is the medical officer from the Immunization Services Division from the Centers for Disease Control and Prevention. Dr. Lee is also a hospitalist who sees patients at the Grady Memorial Hospital in Atlanta. Dr. Lee, thank you very much for being here. And we hope you have a good amount of questions for all your data you're going to share with us. And please, let me just remind everybody to please ask questions, and I'll ask the speakers their questions after the presentations. Dr. Lee, just let Susie know what's, to turn the slide to next, and she'll change that for you.
All right. Good evening, good afternoon. Thank you so much for having me. My name is James Lee. I'm one of the medical officers at CDC with a focus on adult immunizations. I'm subbing in for my colleagues Tara Jatlui, who's another ACOG member. So I'm sorry you're getting an internist instead of a OBGYN today, but we'll try to make do. Okay, right. Let's keep going. Next slide, please. All right. So next slide. So first, I want to sort of take a moment here to start with the recommended adult immunization schedule from ACIP that's recommended earlier this year. That actually, since we just had an ACIP meeting last week, we're going to need to update it some more. I want to sort of take a moment to sort of pause and think about, like what this represents in terms of, scientific progress and, the protection it offers for Americans and, our friends, our families, and our communities. The schedule right here includes vaccines that protect against 17 different antigens. Now, again, there's, the schedule itself is somewhat complex, and then we have apps, we have hand cards, we have all these other things that can help you sort of specify by medical conditions or other indications in other tables. But hopefully those of you here who are medical professionals and healthcare providers will have an EHR that just prompts this for you. And let me sort of then talk a little bit about why this is important. Many of us who care for our patients, we often are trying to do very challenging things. We're trying to get people to quit smoking, to get people to to do calorie restrictions and lose weight. We're trying to, have people take a medicine once a day, twice a day, 3 times a day, or, and, the list goes on. Relative to this, our hope is that, immunization should be a relatively easy and straightforward intervention. Obviously there's a lot of, we over the last few years, and in fact, going back a century, there's always been a lot of debate and controversy around it. But, I want us to think, this is, of all the things, we do for our patients, with our patients, this is one of the things that's hopefully the easiest to accomplish. Next slide, please. All right. We're going to talk a little bit about the ACIP recommendations for pregnant persons, okay? And then we're going to start a little bit with Tdap, okay? Now, the goal of the Tdap vaccine obviously is to protect mom, but it also has had a dramatic impact on protecting babies, and then you can see that from 2005 2006, when we first sort of started talking about Tdap vaccines for pregnant persons, as the evidence accumulated over the following 6 to 8 years, the evolutions with ACIP has evolved. Okay, and at this point, we recommend 1 dose of Tdap vaccine during every pregnancy. Okay, with the optimal timing at around 27 to 36 weeks of gestation. Next slide, please. Let's talk about why this is important. Tdap during the 3rd trimester of pregnancy is 78% effective at preventing pertussis in infants less than 2 months of age. And then meanwhile, even if they do get pertussis, they're less likely to be hospitalized, less likely to be admitted to the ICU, right? And then so again, this is these are convincing and safe vaccines. And then next slide, please. And then if you look at the trend lines for nationally, right, look at this. So the red line right here is the time of maternal Tdap introduction. Okay, the blue line represents the cases of pertussis in children under 2 months old, and then we see the orange line right there, cases of pertussis in children between 6 and 12 months. So what we see during this time is that after maternal Tdap vaccination, as coverage for maternal Tdap vaccination goes up, and you see that in the gray bar starting in 2014, the incidence of infant pertussis goes down pretty dramatically in the purple line. I'm sorry, in the blue line. And then this isn't because there's really this disease has just gone away from our environment, because we still see a baseline of pertussis in the orange line right there that hasn't decreased in the corresponding period. Okay, next slide, please. Now, as with many preventative health services here, we've seen, we have changes in this uptake over time, and then we have changes in, and then we have disparities by race and ethnicity. Okay, so looking, right here, this is preliminary data from the internet panel survey. Okay, capturing pregnant persons right here. So what we see is that from 2019 going to 2023 influenza seasons, we sort of see the percent vaccinated for Tdap among pregnant persons at around 55%. Okay, with a drop in the 2021-2022 seasons. Now, however, if you sort of compare this by race, so let me direct your attention to the purple bar. Okay, representing the vaccine coverage for 2021 to 2022, right? We could see that, white non-Hispanic pregnant persons are at 45% coverage. Black non-Hispanic pregnant persons are at 33.5% coverage. Hispanic pregnant persons are at 46.7%, while other race non-Hispanic pregnant persons are at 53%. So, we see sort of, again, this very, very compelling gap between, Black non-Hispanic, white non-Hispanic pregnant persons that, can and should be addressed. Next slide, please. Likewise, we also recognize that infants are unprotected in a period prior to, their infant immunization for flu vaccines. And then so what we see here is that, again, an evolution of the recommendation around flu vaccines from 1997 on to 2010 as we accumulate more safety and efficacy evidence. Okay, and then again, the vaccination of pregnant women here protects both the mom and the newborn. Okay, we know is safe and is effective. At present, ACIP state recommends that any person who is pregnant or who might be pregnant during the influenza season should receive the influenza vaccine. There's no optimal timing here for, unlike the Tdap vaccine, we really just recommend that you sort of get it early on the flu season so you're protected. Okay, next slide, please. The importance of this, okay, once again, so this reduces the risk of influenza in pregnant persons by about 50%, okay, and it's about 40% effective against influenza-associated hospitalization during the pregnancy. As it turns out, when you have fewer upper respiratory tract infections, you're less likely to use antibiotics, you're less likely to have medical visits, you're less likely to lose work days during already a very challenging time for expecting mothers. Okay. And then also finally, this reduces the risk of influenza hospitalization for infants during the first several months of life. Next slide, please. Now, again, so what we see here is a more challenging time trend for influenza over this period. During the 2019 to 2020 flu season, we sort of had pregnant persons at 65% of overall coverage. Now, in the interval, this has decreased steadily to 48.9. Okay. Now, part of this, we wonder whether there's a spike in influenza coverage during the first parts of COVID, as people sort of use any and all available tools to protect them against respiratory viruses. But the fact that 50% of pregnant persons are unvaccinated for influenza here is a challenge, and is something that we can and should do better on. Okay. Again, what we see here, again, directing your attention to the 2023 flu season. This is the sort of light beigey bar on the right-hand side for each group. We also see here, we see disparities by race. Okay, 48.4% of white pregnant persons are vaccinated versus 30.4 Black non-Hispanic pregnant persons. And then also Asian, and then also in comparison to Asian non-Hispanic pregnant persons at 66.6%. And finally, other races, non-Hispanic at 48.1% here. Okay. Next slide, please. I know that my colleagues, Dr. St. Jean, Dr. Alessandro will be talking a little bit more about the COVID-19 vaccine. So we're gonna move forward with the next few slides. Next slide, please. Okay. Again. So again, what is encouraging about pregnant persons here is that the majority of pregnant persons have been vaccinated for COVID-19 with the primary series. However, a much lower percentage of them are up to date with the current boosters. Next slide, please. All right. So implementation. Now I want to pitch this, for the importance of public health. What we are thinking is that vaccination really is a learned behavior, and it's a culture where you learn that the vaccines available and recommended by your healthcare providers are safe, effective, and does much more good than harm. And then so what we see is that there's association between influenza vaccination during pregnancy and infant influenza vaccination. This in part reflects some of this culture vaccination stuff that I was talking about, but also probably likely representing correlations in terms of barriers to medical care. Okay, next slide, please. Now where NHMA members play a very important role is is making sure these vaccines during pregnancy are offered, okay, and recommended at the visit. So, if we, again, surveying pregnant women, pregnant persons, in the 2021-2022 flu season, we saw that 70% were offered influenza vaccination, meaning that, it's like, okay, we recommend it, please, and then we also have it here in the office. Of those 70%, 64% were vaccinated. Now, another 6% of pregnant persons were recommended this, but didn't receive the offer of getting it in office the same day, and of that, 30% are vaccinated. And finally, 24% of pregnant persons had no recommendation and no offer of influenza vaccine. Okay. So again, these are markers of association. They're not causation, but we see a very compelling association between the offer and the recommendation of influenza vaccine for pregnant persons and their uptake. Next slide. Likewise, we see a pretty similar pattern here with Tdap. Next slide. So all of us who are healthcare providers here, we counsel our patients a certain way. We have our own bedside manners. One of the things that we most critically recommend is that healthcare providers make a strong and empathetic recommendations for vaccines in terms of protecting the pregnant person and protecting the expecting infant. Some of the tools we can use is this SHARE acronym, for providers to share the reason, to highlight some of the positive experience, to take some time to address the questions, remind patients why this protects them and their loved ones again, and then finally really explain the potential causes of some of these diseases, which for our younger patients who can't get pregnant can sometimes seem a little bit remote. Okay. All right, I have a few slides here for reference in terms of the safety data for influenza and Tdap, but I'm going to sort of forego that right now and then yield my time to my colleagues. Thank you.
Thank you very much, Dr. Lee. We're now going to go to our second speaker. Doctor of OBGYN from Westchester Medical Center, Dr. Ashanda St. Jean. And I just want to say that she's been an NHMA Leadership Fellow and is a leader in her own right already. And we hope to see great things from her with the NHMA. And thank you very much for being a speaker today.
Thank you, Dr. Rios, and I am so honored that I was able to complete a fellowship in leadership with the National Hispanic Medical Association, and very grateful for this invitation to speak tonight, so thank you. Let's get started on the first slide, please. So I have no disclosures and no conflicts of interest. Next slide. So let's talk about COVID-19. Now, this is a virus that causes a severe acute respiratory syndrome. And this syndrome can diversify in its type of severity in terms of symptoms. There are mild symptoms which cause fever, malaise, cough, upper respiratory symptoms. And that's what the majority of the population who had COVID had. However, this part does not require hospitalization. It is, in fact, the severe symptoms, the symptoms of dyspnea, of hypoxemia, where your O2 saturation goes below 94% on room air, or the need for oxygenation or ventilation support. This does require hospitalization. In kind of understanding this framework, we can then delve into how the impact of COVID is on pregnancy and pregnant people. Next slide. So what does COVID-19 cause in pregnancy? Well, we know that pregnant people or recently pregnant people with COVID-19 have an increased risk of severe illness and then their non-pregnant peers. And this increased risk of severe illness includes hospitalization, ICU admission, mechanical ventilation, ventilatory support like ECMO, or even death. And this is why we're talking about this, and this is why it is so important for our pregnant patients and recently pregnant patients to be vaccinated against COVID-19. Next slide. So when we look at the clinical manifestations and risk factors of maternal and perinatal outcomes, we have a meta-analysis from December 2019 to June of 2020. And so this included 77 studies and included over 13,000 pregnant patients and 83,000 non-pregnant patients. And what they found is the risk factors for COVID included advanced maternal age, a higher BMI, chronic hypertension, and pre-existing diabetes. And what the outcomes revealed was all-cause mortality, ICU admissions, and invasive need for ventilatory support. But also there were fetal and neonatal outcomes, which included preterm birth, stillbirth, cesarean delivery, and NICU admission. So this has given us so much of a framework, how we can really support and encourage our patients to get vaccinated and why it is so important on the impact of their pregnancy, but also their fetal and neonatal outcomes. Next slide. So here's an overview, right? Pregnant and recently pregnant patients with COVID-19 have an increased risk of more severe illness. And those we talked about, that increased risk includes ICU admission, mechanical ventilation and ventilatory support, including ECMO, and death. But when we look at Black and Hispanic individuals who are pregnant, they appear to have disproportionate COVID-19 infections and death rates. And the CDC includes pregnant and recently pregnant individuals as increased risk for category of severe COVID illness. Now, when we talk about this, I'm just going to reflect on my own personal experience. During the first wave of COVID, I was working in Upper Manhattan in New York City. And what happened is we were inundated with patients who were collapsing in the hospital. We had to have refrigerated trucks outside of our emergency rooms. And this truly impacted the population, the underserved population, the marginalized patients that we serve. And so it's important for us to really note how this impacted Latina women and Black women and how that then kind of progressed onto their pregnancy outcomes and their neonatal outcomes. Next slide. So again, I can't stress this enough, and I guess this is just the same slide again, is the meta-analysis that really included a study of over 13,000 pregnant women and over 83,000 non-pregnant women. And these were the outcomes that we got. And this was helping us to, again, encourage our patients and really enforce the importance of vaccination. Next slide. So here are the cases of COVID among pregnant people by the week of diagnosis. So we see that that first really large spike happened November of 2020, and that's right around Thanksgiving. And then we see another spike in December around 2021, which was around Christmas. And so we see that when there's a congregation of people, right, for family gatherings, that's when this disease was transmitted. And this is why we talk about this, because it has such a severe impact on pregnant people. Next slide. And then when we look at COVID infections in pregnancy, we have to also look a little closer at ICU admissions and deaths. And so as we see here, the light blue color, it denotes ICU admissions, whereas the black denotes deaths. So as we see in the beginning in 2020, we see a large increase in ICU admissions. And then when we look at 2021, when we did actually start to have our vaccination, we see that we still had these spike in ICU admissions and even deaths. And this is also because there were vaccine hesitancy and a lack of vaccine confidence. And so when we kind of translate this information to our patients, this whole entire graph denotes a total amount of cases of over 123,000 pregnant persons. However, There were over 21,000 hospitalized and 159 deaths. Next slide. So again, this schematic is looking at the age groups that were affected by COVID-19 in pregnant people. And as we see, and it's not surprising at all that we had an increase in numbers between 25 to 29 and 30 to 34 and 35 to 39. So this is the reproductive age, right? Where we have the highest prevalence of pregnancy. So it would not be unusual for us to see how COVID-19 impacted women of their reproductive ages or pregnant people of their reproductive ages, and kind of how we had this higher incidence and prevalence of COVID-19. Next slide. So again, one of the things we want to talk about today specifically is the impact of COVID in pregnancy by race and ethnicity in the United States. And again, this is from January of 2020 to February of 2022. And as we see here, Hispanic or Latino patients had one of the highest incidents of COVID in pregnancy. And I think this goes back to what Dr. Rios had said in the beginning of the webinar, is that many of our Latino patients were essential workers. And again, and when we have multiple generations living in one home, this is how this communicable disease was spread. So we really have to take importance of the impact of COVID and what it did to so many people. You know, I recently attended an event where the speaker noted, you can tell the impact and also the racial disparities of COVID based on if someone knows someone who died of COVID. I personally knew of 11 people that died, and this is family, friends, neighbors, relatives. This is not patients I took care of. So again, we see how it can impact communities. And that's why we really, really have to stress the importance of vaccination and really restore confidence in the COVID vaccine. Next slide. So let's just talk a little bit about the fetal and neonatal outcomes. The vertical transmission of COVID may occur, but it appears to be uncommon. Pregnant patients with COVID are at an increased risk of preterm birth. There is some data that suggests there is also an increased risk of other adverse pregnancy complications, such as preeclampsia, coagulopathy, and stillbirth. And the data now indicates that neonates born to patients with COVID-19 are also at an increased risk for admission to neonatal intensive care units, to the NICU. Next slide. Now, when we talk about fetal and neonatal outcomes, we must talk about there is some protective effect. So the latest study published in JAMA reveals pregnant patients vaccinated or with natural COVID infection during pregnancy, those newborns may have COVID-19 antibodies up to 6 months of life. So again, this alone should be another way that we can demonstrate the impact of COVID vaccination and how it can improve the fetal and neonatal outcomes of the newborns. Next slide. So this schematic is kind of detailed and I kind of want to gloss over it. I really want to just make sure you understand the timeline. And this is from ACOG, the American College of Obstetrics and Gynecology, of the COVID-19 vaccine recommendations. So as early as December of 2020, Pfizer vaccine was recommended for pregnant persons, but pregnant persons were excluded from the clinical trials. So we were relying on animal model data in pregnancy, but that demonstrated no safety signals indicated. And then in December 13th of 2020, ACOG recommended pregnant patients to have access to COVID-19 vaccines. And they recommended risk-benefit conversations with clinicians. And I can tell you, I participated in many of those conversations to just really calm the fears of our patients, given that there was concern that they were excluded from the clinical trials. In December 21st of 2020, Moderna, the vaccine was recommended, and ACOG Practice Advisory revised to recommend access to both mRNA vaccinations. And as of January of 2021, ACOG received reports of pregnant people being denied access to COVID vaccines. And this is actually very true. I've had patients at that time actually come and ask me for a letter so that they could present it to the vaccine site so that they would be vaccinated. Despite that, ACOG developed the 8 key recommendations for COVID-19 vaccines and distribute them to the vaccine sites. Next slide. So as we progress into the next year of January 2021, the CDC began reporting numbers of people enrolled in VSafe after vaccine health checkers who identified as pregnant. So VSafe was one of our measures that really was allowed people to report any side effects or any kind of impact of the vaccination. And then in February, ACOG led a statement saying that maternal immunization task force and the vaccine should be available to pregnant individuals. And that's the most important thing I want you to understand. The vaccine is recommended and encouraged by ACOG for all of our pregnant patients and recently pregnant patients and lactating patients, and also patients who are looking to explore their fertility and thinking about conceiving. Next slide. So again, this schematic talks about how the new vaccine is developed, how it was approved, and how it was manufactured. It wasn't something that happened overnight. And that was one of the fears that a lot of my patients had and a lot of concerns that were brought to the forefront. They thought it was something that happened overnight, whereas there were several phases, phase 1, 2, and 3. Initially, there were 20 to 100 healthy volunteers. In phase 2, there were several hundred volunteers. In phase 3, there were hundreds or thousands of volunteers. And with this, vaccines were made in batches called lots, and manufacturers tested all of the lots for safety, for purity, and for potency. And the FDA inspected manufactured facilities and were regularly to ensure quality and safety. Next slide. So how does the COVID-19 vaccine work? Well, the genetic material instructs your body to make a protein that is part of the virus that causes COVID-19. The protein tricks your immune system into thinking it sees the COVID-19 virus. Your immune system then makes antibodies and other defenses. And if a person is later exposed to the actual COVID-19 virus, the body is now able to recognize the virus and make antibodies to fight it. Next slide. So Pfizer and Moderna are both mRNA vaccines. They consist of messenger RNA that's encapsulated by a lipid nanoparticle for delivery to the host cells. It utilizes the body's own cells to generate the coronavirus spike protein that stimulates immune cells to create antibodies against COVID-19. So there's a few things that we always want to make sure our patients understand. It is not a live virus. There's no adjunct. It does not enter the nucleus. It does not alter human DNA, and it does not cause any genetic changes. Next slide. Now, this schematic is a bit more pathophysiologic in terms of how the mRNA vaccine approaches and how it mimics a native viral infection that leads to a B and T cell response. Next slide. So what about the efficacy? Well, all current available COVID-19 vaccines have demonstrated high efficacy. Evidence suggests fully vaccinated people are less likely to have asymptomatic infection or transmit infection to others. Those with up-to-date vaccinations are less likely to experience severe illness and serious adverse outcomes. Next slide. And also, they can keep you from getting and spreading the COVID-19 virus. It can prevent you from developing serious illness if you get COVID-19. And getting vaccinated may also protect people around you, especially people at increased risk for severe illness. So going back to what Dr. Rios had said about multiple generations living in the home together, especially if you have older persons, if you are vaccinated, you will also protect them around you. Next slide. vaccine efficacy. So I'm going to kind of rush through. I have a little bit of more time, not that much time left, but this shows very quickly that they had over 7,500 vaccinated pregnant people and about the same amount of unvaccinated pregnant people. And if we look at this, it also shows that those that were vaccinated had a lower risk of infection amongst pregnant people. So again, this is evidence-based, and we know that this vaccine is efficacious in preventing severe illness. Next slide. So again, I must say the COVID-19 vaccine, ACOG strongly recommends all eligible persons greater than 12 years old, including pregnant and lactating individuals, to receive the COVID vaccine in the vaccine series. Any of the currently authorized COVID-19 vaccines can be administered to pregnant and recently pregnant or lactating people. Next slide. The mRNA COVID vaccines are preferred over the J&J. And ACOG recommends that pregnant and recently pregnant patients up to 6 weeks postpartum receive a booster dose of COVID-19 vaccine following the completion of their initial COVID-19 vaccine or vaccine series. Next slide. So again, when we talk about the safety of the vaccine during pregnancy, there are no safety concerns that were found in animal studies. There's no adverse pregnancy-related outcomes occurred in previous or clinical trials that were used the same vaccine platform. And vaccines do not cause infection, including in pregnant patients or their babies. Next slide. So again, I'm just going to briefly talk about fertility, because as we look at our patients through the lifespan, there is also a concern how the vaccine could affect their fertility. And claims that link the vaccine to infertility are unfounded. Given the mechanism of action and the safety profile of the mRNA vaccines in non-pregnant individuals, COVID-19 mRNA vaccines are not a cause of infertility. And again, we understand that is a concern of patients, and that's why we want to make sure that this is addressed and that they have the answers that they want. Next slide. So one last study is that there is no impact of COVID vaccines on one's fertility. And there were studies that were done, one at Mount Sinai that investigated fertility outcomes after vaccination that included egg quality, embryo quality, and development, pregnancy rates, and early miscarriage. And the study showed no difference in rates of adverse outcomes in vaccinated compared to unvaccinated patients. Next slide. So again, vaccinations, COVID vaccine is recommended in lactating individuals. It's strongly recommended by ACOG. There is a safety that is demonstrated. There's no need to avoid initiation or discontinuing breastfeeding in patients who are vaccinated. And they found that the antibodies in their breast milk suggest that potent protective effect against infection in the infant, although the degree is still being examined, and we don't know exactly the extent of the clinical benefit. Next slide. So what are the impact of COVID-19 on pregnant patients? Well, let's just talk about what happened, right? There was an increase in maternal mental health, anxiety, and depression. There was an increase in domestic violence. There was a decrease in prenatal care visits. Working families struggled with increased childcare demands because many of the schools closed and there was virtual home learning. And there was also a loss of income due to unemployment or just income loss whatsoever. Next slide. And there were barriers to seek care initially during the pandemic. Many in-person visits were transferred to telemedicine visits, and many, if you did not have a smart device or broadband, Wi-Fi, or cellular data, you weren't able to participate in those kind of virtual platform telemedicine visits. There were also transportation needs. Homeschooling, so then if you didn't have childcare, you had to stay home with your child as well. Unemployment, lacking medical insurance coverage. Also anxiety and fear of medical facilities and offices. Patients did not want to come in. They were fearful of getting this from other people. And then there was those who had COVID symptoms and who were in quarantine themselves. Next slide. So what were the impacts? Well, greater than a third of Black and Hispanic New Yorkers were infected during the initial wave of COVID-19. They had twice the infection rate than white New Yorkers. 39% of COVID-related deaths occurred amongst Black people. And while Black people only make up 15% of the population. So that's quite traumatic. Next slide. So how do the social determinants of health impact all of this? Well, again, healthcare access, lack of insurance coverage, unstable housing, food insecurity, lack of transportation, income, education, health education literacy, and then language barriers. There were so many social determinants of health that impacted patients during this time. Next slide. So what do? How do we build vaccine confidence, right? It's normal for people to have questions, right? So what we want to do is listen. We want to share. Many times I had to share my own personal stories, my own testimony, my own family experiences. Part of that also, that circle is educating, supporting, and hopefully vaccinating. And I learned that this doesn't happen in a one time. Sometimes there were multiple visits, multiple conversations where finally my patients were ready to be vaccinated. Next slide. So again, going through the myths that are out there. There is so much misinformation, whether it's on the internet, whether it's on social media, that our patients are presented to our patients. So we have to really kind of tackle those myths and provide facts. So it was not rushed, or that it isn't safe, that's a myth. It changes your DNA, that's a myth. It can give you COVID, that's a myth. It contains egg protein, that's a myth. It causes side effects, that's a myth. It can render a woman infertile, that's a myth. So again, what are the facts? Researchers took no safety shortcuts. Large studies show that the vaccine is safe. It's impossible for a vaccine to change your DNA. It doesn't have egg protein and can be given to patients or people with egg allergies. And there's no evidence that the vaccine causes infertility. Next slide. So how do we foster vaccine confidence? Well, we have to understand the community that we are speaking with. We have to have understanding, trust, and sharing. We have to engage our community. There needs to be bi-directional communication. We need to partner with faith-based organizations and leaders of that community. We have to understand there's an impact of social media. We have to really elevate the personalized stories and testimonies. And we want to do this with culturally sensitive themes and culturally sensitive presence. Next slide. So again, fostering vaccine confidence, well, we have to be generous of time and spirit, understanding, thoughtfulness, humility, compassion, empathy, and providing judgment-free and respectful care. Next slide. So this is one of the CDC's health equity strategies. It's using data-driven approaches, fostering meaningful engagement with community and institutions and diversity of leaders, leading culturally responsive outreach, and reducing the stigma that may be associated with race and ethnicity. Next slide. So again, when we foster and really elevate vaccine confidence, we're educating our patients, we're amplifying their voice, and we're normalizing shared decision-making. Next slide. And I just want to leave with this quote, make a career of humanity. Commit yourself to the noble structure for equal rights. You will make a greater person of yourself and a greater nation of your country and a finer world to live in. Thank you for this time tonight.
Thank you, Dr. St. Jean. Now for our last speaker, who will continue to discuss strategies to promote maternal vaccinations against COVID-19, we have Dr. Donald Alcindor, who's Associate Professor from the Meharry Medical College in Tennessee. Dr. Alcindor. And just a reminder, anybody has questions, please type them into the Q&A box. And we are here until 15 minutes past the hour.
Yes, I wear a lot of hats. The one that's most important here is my work with the FDA as the Advisory Committee for the American Lung Association COVID-19 Action Committee. I serve as the Research Director for the State of Tennessee SEAL program, which is Community Engaged Alliance Against COVID-19. I also serve as the Institute for Health Disparities Director and the Equisomes and the Equity and Exposomes. And of course, recently I've been working with clinical trial associates to promote the Pfizer multivalent vaccine for people that are older. Next slide, please. So I have some disclosures. I'm a site investigator for the current Moderna HCMV vaccine trial at Meharry. I've served as an HCMV expert for HHS. I'm working with clinical trial associates in Nashville for the Pfizer multivalent vaccine that includes COVID, influenza, and respiratory syncytial virus. I've received funding from Merck to examine vaccinations from expecting minority moms to improve pregnancy care. And here I'm looking at 3 different vaccines that are currently recommended by ACOG for pregnant women, and that is Tdap, influenza, and COVID-19. I also have a patent pending for an in vivo morpholino, which is a dendrimer that is used as an intervention for COVID-19 infection. Next slide. And so there, in terms of the national and public health emergency declarations that were put in place, that actually allowed us to witness the allocation of about $5.4 trillion to finance the COVID-19 epidemic so far. And the idea is that the contributing programs that you see there that ushered in this emergency declaration, and of course, some of the major governmental flexibilities that allowed this via COVID-19 federal emergency declarations are listed. And so all of this had to happen to protect the public during the COVID pandemic and ongoing, because COVID is still with us. Next slide. And so the one thing that is very clear to me is that if you're pregnant and you're uninsured, there's going to be problems for you, and you have to be able to basically deal with those challenges. And it turns out when we look where uninsured individuals live in the United States, and that is the average for the United States is about 10.2% of their citizens per state. When you look at certain states in the so-called Bible Belt, what you see is those states that are considered southern states have the highest incidence of uninsured individuals. And again, this so-called citadel of disparities that represented in southern states, you will see this for infant mortality, HIV, diabetes, obesity, and you can go on and on. Next slide, please. And so pregnancy-related deaths in the US increased during the COVID pandemic. So about 32.9% maternal deaths per 100,000 live births reported in 2021. And of course, 23.8 deaths per 100,000 after basically the vaccine was on its way in terms of penetrance in the population. The mortality rate of Black women in the United States was 69.9%. I'm sorry, 69.9 deaths per 100,000 live births in 2021, and about 3 times higher than white and Hispanic women. And so what we see very clearly in the United States, one of the highest rates of pregnancy-related deaths among developed countries. And it's recorded more than 1,200 deaths in pregnant women in 2021, compared to 861 in 2020 and 754 in 2019. Next slide, please. And so when we look at over time, and I've seen people with more current data, what we clearly see is that when we look at the receipt of COVID-19 boosters by race and ethnicity, and of course, what we see is Hispanic and Black women are lagging in terms of getting the booster for COVID-19. Next slide. And so this is the same information showing that the impact of boosters among race and ethnicity. You can see that Hispanic and African-American women are behind in terms of getting their boosters for COVID-19. Next slide. And so when we look at vaccines that are recommended during pregnancy, those that are routine, that includes Tdap, influenza, and now COVID-19, there are certain ones that are contraindicated and those that are of special circumstances. But again, all of this had to do with ACOG and other bodies approving COVID-19 for vaccination. And of course, the FDA approved Pfizer and Moderna in particular. Next slide. And so we've written about this in so many ways, looking at pregnant women in general. And of course, strategies to improve vaccine confidence and uptake is something that we really wanted to do. And you have to do this in the community. This has to be done in person. Next slide. And so what is clear is that antibodies to SARS-CoV-2 has been found in the umbilical cord blood and in breast milk following maternal vaccination, which might provide protection to the infant. However, vaccination rates during pregnancy remains low. And for us out in the community, we are having a challenge trying to get pregnant women to be vaccinated. That's clear. And of course, part of the reasons why we're here is that historically pregnant and lactating women, our people, have been excluded from clinical trials because of concerns for legal liability and confusion about what is permissible for a regulatory and ethical perspective. Next slide. And so when we look at the currently recommended vaccine during pregnancy, it is clear that Tdap and influenza are ones that are at this point more favorable than getting a COVID-19 vaccine. And I just want to say that Pfizer and Moderna have led the way in this. And of course, Johnson & Johnson, up until now, has been put aside in terms of being recommended by ACOG. And most recently, Johnson & Johnson's emergency use authorization has been revoked by the FDA. Next slide. And so when we look at maternal complications, it is very clear that during pregnancy, she goes through a increased cardiopulmonary load because she is carrying a semi-allogeneic fetus. And so by nature, the immune system has to undergo through a physiological change to allow immune tolerance to carry this child. And so that results from a Th1 to a Th2 response. And if she is unvaccinated for COVID, she has an increased risk of symptomatic disease, hospitalization, ICU administrations, mortality, and of course, neonatal complications. And of course, if she is able to receive the COVID vaccine, there are clear benefits. But it turns out that because of her susceptibility, because of increased cardiopulmonary load, she is also highly susceptible to other respiratory tract infections, including influenza. Next slide. Neonatal complications in a baby born to a mother that's unvaccinated, it's very clear they would have an increase in preterm birth, stillbirth, trophoblast necrosis, placental insufficient, even prenatal death. And of course, if she's vaccinated, there are the counter benefits. Next slide. And so when you look at pregnancy complications overall, again, maternal death is a possibility. And we have seen where the baby comes home through interactions with Vanderbilt, the baby comes home and the mother does not. And so that could be pregnancy loss, preterm birth, gestational diabetes, and preeclampsia. Fetal and neonatal complications are many. And of course, long-term health issues as well for the mother that you see there. Next slide. And so when you look at COVID-19 in pregnant women, in this study, more than 125,000 laboratory confirmed cases, more than 2,200 of them, 22,000 pregnant women were hospitalized, and 161 reported deaths in these pregnant women. But when you look at those women that were vaccinated, it is very clear there's a difference in vaccination when it comes to mortality associated with pregnant women. Next slide. And so this may be data that is a little bit dated, but at the height of the epidemic, Hispanic women were 6 times more likely than white, non-Hispanic pregnant women to have COVID, and Black women 4 times the non-Hispanic whites to have COVID. And of course, at that time, it was very important for CDC guidelines to be followed. Next slide. And so this is a study that's ongoing. And the idea is that they are following pregnant women and they are looking long-term because long COVID is a problem. This is part of the recovery study that is looking at long-term effects of COVID-19 on pregnant women that includes long COVID. And so we will hopefully have answers to these questions because long COVID is something that we don't talk much about, but it could be here and has been here for many people, some people as long as 3 years suffering from recurrent symptoms associated with COVID that have not been able to shake. It's also clear that vaccinations can reduce the number of symptoms of COVID even after diagnosis with long COVID. Next slide. And so the importance of antibodies during pregnancy is very clear, that antibodies by way of maternal circulation and by breastfeeding, you're able to basically transfer these antibodies to the developing fetus. And of course, after the child is born, by way of breastfeeding, you will still get antibodies being produced that are delivered to the baby in breast milk. And so pre-existing antibodies, vaccine-induced antibodies given to the infant by breastfeeding over 6 months in that time. And of course, you can see here, day 14, most of the benefits are gone at that point, but day 4 to 14, the transition milk, you see higher levels of antibody. And of course, the highest levels of antibody is seen in the colostrum very early on after birth. Next slide. And so it is very clear that by way of lactation or maternal circulation, you're able to transfer these antibodies to the neonate. And of course, over time, these antibodies more likely can offer protection to the child after birth. And so more studies are being done to give specifics on this. Next slide. And so it's very clear that vertical transmission of COVID is relatively low. And so this is compared to not being able to find virus in nasopharyngeal swabs of the baby after birth, amniotic fluid, cord blood, and breast milk. So again, vertical transmission of COVID to the baby is relatively low. Next slide. And so breastfeeding is something that's important, even for a mother that's been diagnosed with COVID. And so a woman with COVID-19 should be supported to breastfeed safely, hold her newborn skin to skin, and share a room with her baby. And of course, safe practices are done during this time. Next slide. And so many women, particularly here in Tennessee, we have 95 counties, and large percent of those counties, about 78 to 80 of those counties, are rural counties. And that means people will have difficulty in traveling for medical services. This requires telehealth, and telehealth was certainly used more than ever during the COVID pandemic. And of course, giving people lactation support, virtual postpartum visits, mental health care, online communications with providers, prenatal care visits for women that couldn't make it, and are concerned about going into the clinic thinking that they would contract COVID there. And of course, consultation with specialists, maternal fetal medicine, and genetic counseling. Next slide. And so this is what I really wanted to show here, is us out in the community. In the beginning, Meharry, on our medical college campus, we were out there testing people. It was very clear that medically underserved communities would have a difficult time with COVID. And of course, this includes lack of access to vaccine testing. Lack of access to COVID-19 testing and vaccines. And so we worked with the Bloomberg Foundation and the Greenwood Initiative to acquire a mobile unit to be able to go to these underserved communities and deliver testing, information, and COVID-19 vaccine access to these communities where they live, in-house. Next slide. And of course, every day I was on the news talking about COVID and talking about the need for vaccinations. One of the things we did was baby showers in Nashville. And of course, expecting mothers. And at these vaccine events, we would have 200 pregnant mothers show up. And again, we had a difficult time trying to get these mothers to go away from misinformation that was deeply rooted in their thinking about the vaccine, and particularly infertility, and of course, the side effects. Many of these mothers were first-time mothers and were very reluctant to do anything that might harm their babies. Next slide. And of course, in the Hispanic Latinx community, we would go to a place called Plaza Mariachi. We had a partnership with them along with the Tennessee Department of Health. And there we vaccinated families. This was a family vaccination Saturday. And Hispanic Latinx communities are highly motivated to be vaccinated. And of course, it made our work a lot easier when people are willing to vaccinate. And so whether they were pregnant or not, we had situations where the whole family would come in and ask for vaccinations. We didn't have to do any convincing for them to be vaccinated. So this was important. Next slide. And here we got a pop-up vaccine event. Here we're giving gift cards to these women and giving them information. And of course, we have our vaccinators there as well. Next slide. Again, we have our drive-in baby showers where the mother doesn't even have to get out of the car. We will show her information on the drive-in screen. And of course, if they want a vaccination or information, they can get that on site. Next slide. This is our CBO Help to Moms. This is a community-based organization that we have and we work with to bring in moms. And these are recently delivered moms and moms that are still pregnant. And here we provide information about vaccines. We have wraparound services for them that includes insurance and information about other things as well. Next slide. And we have, of course, our diaper giveaway. We found that in order to get people in the door, we had to be able to provide things to meet their immediate needs. Next slide. And of course, our pediatric back to school immunization event is every year. And in this case, we are looking to vaccinate every child that comes through the door. But again, that has to go through the mother for consent. And of course, this is something that we do for about a week from late July to early August. Next slide. And of course, I go to PTO events, giving out vaccine information. We have our vaccinators there, but this is one of the few opportunities that we're able to encounter mothers and children at the same time, at the same place. Next slide. And of course, for Christmas, we also have our Christmas giveaway where mothers can come in, get toys for their babies. Some of them are pregnant. And at the same time, in the other room, we have a vaccinator there ready to vaccinate people that want them. Next slide. Next slide. And here's our mobile unit, and we travel with nurse practitioners. I also am embedded with this mobile unit for information and questions people might have about vaccines. And this was basically given to as a gift from a larger investment from the Bloomberg Philanthropies, the Greenwood Foundation. And we continue to do this work now. Yes, next slide. We also have specific surveys for expecting minority mothers and COVID-19. We gather this information. We're looking to publish this information in journals. This is IRB approved, and this has worked well for us. Next slide. And of course, we push the new booster. This is the Omicron bivalent booster. Next slide. And next slide. And of course, clearly here we have an updated vaccine that includes both the ancestral strain mRNA spike protein cassette as part of an mRNA. And of course, we have part of the BA4 and the BA5 spike protein that represents the Omicron lineage. And so this is given together. And of course, this vaccine is updated. We expect another update of the vaccine to include a more recent Omicron version. This is the XBB 1.5, I think it is. And of course, this may be available maybe September, October as a new vaccination. Next slide. And of course, we see that there's clearly an age difference in uptake of this new booster. We were very concerned of the poor uptake of this booster recently. And so we are certainly worried about this because people often feel that they don't have to get another booster or another vaccine. And so we clearly see that people that are older are very good at getting vaccines compared to other age groups. Next slide. And of course, by age group, we see that the older people are, the more likely they will get a vaccine in the state of Tennessee. And of course, very young children, we have had difficult time convincing parents to vaccinate their very young children. Next slide. And of course, Blacks are lagging in terms of bivalent booster in the state of Tennessee. We see that Hispanics lead the way in Tennessee in receiving the bivalent booster. Next slide. And of course, what we've seen with COVID vaccines in terms of the primary series, we see it with the bivalent boosters. That is, the more central, middle Tennessee counties will take up the vaccine at a higher rate than some of the other rural peripheral counties in Tennessee. Next slide. And so in terms of publication, we are on number 13 here. We've published everything you can think about in terms of racial disparities, vaccine hesitancy, the reagent for treating SARS-CoV-2 as a therapeutic intervention. We've looked at rural communities. We've also published our mobile vaccination program. We've also published breakthrough infections, because that's what's a big thing at one time. We published the pregnant minority women work as well. Next slide. And of course, we go on. We've recently published the bivalent vaccine and booster with implications for vulnerable populations. Right now, we're looking to publish the public health and national emergency declarations ending as of May 11, 2023, and the impact it would have on underserved populations in Tennessee. Next slide. And of course, my special issue in the Journal of Vaccines is available for people that are interested in sending a paper to that special issue. It is referred to as Emerging Viral Pathogens and Vaccine Access for Vulnerable Populations. Next slide. And the RECOVER trial will do something that I think is very important, and that is include pregnant adult enrollment in this trial to look at long COVID in pregnant women. Next slide. Mm-hmm. That's it.
Okay. Okay. Well, thank you, Dr. Elsendorf. We do have some questions. I'm going to ask just a couple questions really fast. One, Dr. Lee, any recommendation on Mpox for the pregnant women population?
Yeah. Oh, I have to pull up the webpage to find out what I'm supposed to say. But but basically, you know, the fact of the matter is, you know, this is an epidemic that has very highly concentrated in people who identify as men, and then, you know, is concentrated with people who have like close, intimate contacts, and then that's how it transmits. So, you know, I'll look up the webpage, I'll type it in, but I would say this is not high on the priority list of, you know, things for women to get vaccinated. Right.
Okay. Dr. St. Jean, in New York, I know there's undocumented people, and especially you know, in our communities of color, we have a lot of fertility and a lot of people getting pregnant. Any special recommendations on how to convince the undocumented to come in for health care and vaccinations?
Yeah, I mean, one of the biggest benefits of New York State is we're a sanctuary state. So, you know, there is an ease for our pregnant patients, whether documented or not, to get Medicaid, to get health insurance, and to get prenatal care. So we always encourage prenatal care, especially starting in the first trimester. In addition to that, you know, we have to have more of a shared lived experience in allowing our patients' voice to be amplified. You know, many times there were multiple conversations I needed to have with patients and listening to what their experience was before they even accepted getting vaccine. And I have to also state that, you know, these conversations were multiple with many information distributed, but they were respectful. And I think that has to be a patient-centered approach where there's always respect and there's non-judgment, but also an understanding and just a validation of their lived experience. And I just say that sometimes it happens after a few of those talks, but our success is when it does happen and that we have the best outcomes for our patients.
Right. No, thank you. And I think it is important to talk more about the importance of sharing stories with your patients from other patients so that they feel more comfortable too. Dr. Elsendorf, just a quick question about any guidance that you have on the upcoming flu season. You know, now the new guidance about having a combined updated COVID and flu vaccine recommendations, and how does that affect the recommendations for pregnant women?
I think what you'll see is that if this is more effective than what we've seen in the past, and we get better uptake of this vaccine because of that combination, I think it may be a good thing. But what I'm concerned about is the COVID component of that vaccine, making that vaccine something that would make pregnant women more hesitant. They are used to getting an influenza vaccine, but when it's combined with COVID, we might see the same level of hesitancy that we've seen in the general population of pregnant women for the COVID-only vaccine. And that is my concern. And so when they know that this is a combination, they might think that that COVID component is the component that they don't want to be a part of, because I'm just saying that in these pop-up events and all of our baby showers, these young women, I mean, you are hard pressed to get them to get a vaccine. And of course, the information in terms of misinformation that they have, they simply won't give. They won't budge on this information. And so we continue to come up with many things to try and encourage them to improve vaccine confidence and uptake among those populations. But I hope that the efficacy of that combination will make people come to the table and vaccinate.
Okay, well, with that note, let me just say on a positive note, we learned a lot tonight from all of you. I want to thank all of you again for giving us your time. I want to thank all the audience, and to please let others know about our webinars, especially that we are shifting a little bit from just COVID to vaccinations for adults, all types of adults. Misinformation is very real in our communities, so we hope to find more speakers, and those of you out there who want to recommend speakers, we're always looking for the experts who take care of our communities. And also from CDC, Dr. Lee, we really appreciate CDC and all you do. You know, we want to continue working with CDC on again, for adult vaccinations especially. So thank you very much. And I know there's a last slide from our staff, Susie. Yeah, just a heads up on NHMA chapter events in different parts of the country to meet our doctors and medical students and residents. Nebraska, Omaha, Nebraska, September 22nd. The Los Angeles area is actually, it's going to be in Pasadena at a Mexican restaurant in the Southern California chapter, October 20th. Nevada, I'm not sure if it's in Reno or Las Vegas, but we have a statewide chapter in Nevada, November 4th, and also in Texas and San Antonio, January 2024. And I guess Arizona, Phoenix, Arizona is still to be determined. We have other chapters that are coming online in person and building our networks with medical schools and clinics and hospitals. So we welcome you all to join us and to join NHMA. So with that, I'm going to say thank you to our staff. Thank you, Dr. Elsendorf. Thank you, Dr. Lee. Thank you, Dr. Sanchez.
Thank you. Thank you.
And here's our QR codes. Sorry. The QR codes here to sign up to be a champion, upcoming events. And let me leave that there for people to see. And also this is our reminder for the post-webinar survey. And we will be emailing everybody this information again. So thank you all very much, and I look forward to the next time.
Thank you.
Thank you.
Mm-hmm.